So you know where sodium goes, water goes, okay? So therefore, you could have swelling with that. So that would show where in the kidney that there is a problem. You all understand that? Then chronic glomerulonephritis, it causes scar tissue, that can lead up to nephritis. Pyelonephritis is in the little pyramids of the kidney. They're kind of triangle shaped. I kind of compare them to teeth, chiclets or something like that. Pyelonephritis is the inflammation of the kidneys and other infections. Obstruction can cause a urinary tract infection and can cause chronic kidney disease. If we keep having that, they'll probably need to go in and check and see where there is a blockage or a stricture. Okay, it can be hereditary. What does that mean? Vascular disorders, what kind of vascular disorders you think?
Heart attack or stroke?
That's good. How about, high cholesterol that causes the arteries to block? Okay, that's another problem. And I just mentioned the obstruction of the urinary tract, that could be from the stone. The bladder also gets stones like the kidney does. Okay. And then medication or toxic agents can cause damage to the kidneys, especially long-term use of ibuprofen or Tylenol. So what is nephrosclerosis? Of the renal arteries, yes. And what does that lead to? Commonly, when your veins are constricted, what happens to your blood pressure? Yes. And then the ever popular diabetes is the other cause that affects so many systems. The two types of nephrosclerosis are acute hypertensive that causes hypertension, and then benign, which does not spread. It's found in older adults with atherosclerosis, which is what I just mentioned, and hypertension. They rarely have symptoms, and then we treat them with ACEs. What are those? Which ones? Right, lisinopril. Sometimes hydrochlorothiazide. Okay, glomerular diseases is in this part of the nephron, right here. That controls a lot. So it first filters out the blood, so what do you think is gonna happen with the blood that is not filtered? What can that lead to? It can lead to sepsis. So we need to keep on checking these patients, especially their INOs, their weights, first thing in the morning. So glomerulonephritis can be chronic, which happens off and on, and then acute comes on very rapidly, and then nephrotic syndrome is what we're going to talk about. So in acute nephrotic syndrome, what part of the kidneys does it affect? The glomerulus, right here again. Okay, this is the glomerulus, that little tight web vessel that starts separating the blood and the plasma and the urine. So what's gonna happen to them? What symptoms do you think they'll have? What about their urine? What can they have in their urine?
Blood.
Yes, so that's hematuria. So where sodium goes, water goes. So what do you think the next symptom is? Yes. They can also, if they eat a lot of protein, can have proteinuria. It's also indicative of diabetes mellitus. And then hypertension and azotemia. Okay, y'all have any questions? So we're going to make sure that the disease doesn't progress to acute. They need to be seen probably once every 3 months to make sure that their numbers aren't going up or coming down, that they're mostly getting in the middle, close to normal. have for them. How are we gonna fix them? How are we gonna make them better? They need to modify their diet. And then we're gonna give them supportive care, make sure that they know the stages and everything of acute nephrotic syndrome. So we just kinda talked about that, the patient assessment, what are they gonna have? What,
Daily height
yes. What else? You can also monitor their blood pressure too. Make sure you check their INOs. The fluid and dietary restrictions are a lot like those that have, dialysis. We're gonna educate the patient, and then we're gonna follow up with the care to make sure that they understand what they're supposed to do. Okay, so causes of chronic glomerulonephritis are related to the glomerulus. Okay, again, that's very important. That's where it all starts at. So they're gonna get acute glomerulonephritis. It can cause hypertensive nephrosclerosis, hyperlipidemia, and then several other causes of glomerular damage. Can be from use of aspirin and Tylenol and Motrin. So the diagnosis or nursing diagnosis would be renal insufficiency or failure. And does that come on with chronic, does that come on immediately, or is it after you've had nephritis for a while? Okay. What tests would we do with that to figure out what they have, what's going on? To do that, we're gonna do a urine with specific gravity that shows the CAS, proteinuria, which is where it's not filtering out, and any electrolyte imbalances, and then hypoalbuminemia. So a lot of patients that have glomerulonephritis in the hospital, we usually give them plasma. Okay. So here is where'd my beans go? Here is parts of the kidney. Okay, so a healthy kidney, as y'all can see, is on the left. An unhealthy, kidney is on the right side. So what do these look like to y'all? They kinda look like teeth or corn to me, okay? So that's an easy way to remember that. And then this one is unhealthy. Why is it unhealthy? What's going on with it?
It's inflamed.
Yeah, this last part here is inflammation, okay? So how are we gonna assess them? It's pretty much gonna be the same thing. We're gonna watch, their INOs, and then for any fluid and electrolyte imbalances, their cardiac status, because this is where a lot of the enzymes and the electrolytes are released or they're absorbed. So you can tell how important that is, the proximal convoluted tubule and then the distal convoluted tubule, okay? We're also gonna look at their cardiac status, which I mentioned, the potassium, the sodium, what else, what other electrolyte? Magnesium and, yes, somebody said calcium. Thank you. Neurological status, so what can happen with them, what enzyme builds up in their brain? Come on. Which enzyme would build up in them where they couldn't relate, they don't know where. Yes, it is ammonia. So a lot of patients that have urinary tract infections that are older, what's the first thing we think about when they're confused? Exactly. So y'all can remember that, and hopefully you can remember that. I keep going over it. Provide them emotional support, let them know that they're not alone, that we are there to help them to achieve some type of normalcy of their life. and then of course educate them on self-care. So these are some strips that are related to the hyperkalemia. So where does that come from? It comes from here, the distal convoluted tubule. You see the potassium, and then in the proximal convoluted tubule, what do we see right here? Those two and calcium, okay? So you can see on the slide where the hyperkalemia with excessive amounts of potassium release, these are inverted. And then here you can notice the peak T waves, here, 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 okay? And then this P wave here is almost diminished, okay? Y'all stop me if you have any questions. Okay. So what is nephrotic syndrome? Does anybody know?
Persistent glomerular damage, it's called persistent damage to the glomerulus.
Right. So if there's damage to the glomerular membrane and it's secreting more plasma proteins, what goes along with plasma? Starts with an A.
Albumin.
Yes, yes. So if that is all going out, what do you think their albumin level is gonna be? It's gonna be low. And then, so the albumin is gonna go out and it's gonna cause more edema, okay? And most of the time it's in their abdomen. And we have to go in and tap that or make an insertion and the physician pulls out the excess. Okay, we mentioned this before, you can have chronic glomerulonephritis, it's one of the causes. The ever popular diabetes, which I'm diabetic. Oh, and another funny fact about me is that, can you guess what my middle name is?
Lachey.
Payne, Payne, P-A-Y-N-E, I was Nurse Payne for 20 years. Yes, okay. So the diabetes causes problems within the glomerulus, again, that's the kicker. Amyloidosis and lupus erythematosus, that's characterized by a butterfly rash on the face. Multiple tumors and then renal vein thrombosis. How are we gonna manage that? With medication and then watch their diet. And please teach them the right diet because a lot of them will forget that it's important, it's very important. Okay, so polycystic kidney disease can be genetic. It can be either autosomal dominant in a 30 to 40-year-old or earlier, that's 90%, and they're recessive before they're born, an infant or in utero. So a lot of problems can be seen before they are even delivered. And what is polycystic kidney disease? It's a lot of cysts that are in the kidneys, okay? It can also go to the liver and then vessels in the brain and heart. Here is a normal kidney on the left and a polycystic kidney on the right. Can y'all tell me the difference? A lot of cysts, yeah. All right, this is a even closer up picture of it, and you can tell that this kidney is not gonna function very well. It's only got 2 pyramids in there, so yeah, that's sad. Okay, so renal cancer, is kinda dear to me. I was the educator on the oncology floor for a while because my mother got renal cancer and she was diagnosed in the, as stage 4. So she didn't live even 6 months after they diagnosed her. So that's why, oncology is dear to me. So 5% of all cancers in the United States are renal cancer. That's not a 1, that's a 5. What are the risk factors for renal cancer? What's the number 1?
Yes.
Okay. So if they smoke, you please include that. Along with smoking, a lot of times goes alcohol, okay? have them come in, and then they're gonna diagnose which stage of the cancer that they're in, and then what are some of the symptoms that they would have, because the blood is not filtered. What do you think is gonna happen to their urine?
There's gonna be a lot of urea buildup, and it's gonna eventually flow back into like the liver and the pancreas, and it's gonna cause multi-organ failure.
Yes, so good. It also causes, because the blood is not broken down, you can have hematuria and pain. Where's the closest spot?
The back.
Yes, they're literally right here. Okay. So you can imagine if a football player gets hit in his back, what that could do to their kidneys, and I don't know how they get around not having full body armor on. I would. Okay, they do have unexplained weight loss, so there is an enzyme that is released by the cancer cell that does cause that. It's a true thing. Yeah, so my mother, she loved to eat, and at the end, we could only get, Ensure liquid in her. And she completely changed, she was disoriented, because of the ammonia, because of all of that stuff being released into her blood. And I'm sure at one point they get very septic. Okay, and then the weight loss causes weakness and anemia. So how do we diagnose renal cancer? CT and MRI, an IV urography, and then an angiogram or ultrasound. So my husband, the way I met my husband was in surgery, and he was a scrub, I was a circulator. Years ago, when we were not married, I met him, now we're married. So he did a lot of these nephrectomies, for cancer patients. So what they do is they just take out a wedge of that tumor, and then they can anastomose. You see this bottom little picture right here? This is where it's sewn back together, so that's pretty cool. I need to stop that. Okay, yeah, okay. All right, so this is the cancerous tumor here and within the kidneys, and like I was telling you, it releases these enzymes into the bloodstream. Yes. And my mother, because she was stage 4, the lymph nodes were in good shape. Where did it go to first? It went to the lymph nodes. And she probably lived maybe 3 months after she was diagnosed. All right, so now we're gonna go into another one of my favorites. I was a urology scrub for probably 5 years. We're gonna manage the patients with urinary disorders. Y'all have to stop in your, book at urolithiasis. So what is that word? What does that mean? Yes. And you need to review your learning outcomes, the concepts in the glossary and words that are in there. Make sure you review those. Make sure you're clear on what does what, okay? So we're gonna continue talking about the kidney, but this time urinary conditions, kidney function. We talked about polycystic kidney disease, and then again, glomerulonephritis. So what is one of the most common things that happen with your kidneys? In men and women, the UTI, that's right. And where it happens, where it occurs at, and what it can lead to is very serious. They can get lower urinary tract infections, which is in the bladder, or in the prostate, or in the urethra. Okay? And then an upper urinary tract infection happens where? Happens in the kidneys. And it can be acute or chronic. It can be interstitial, and then they can have also renal abscesses or perirenal abscesses with a UTI. So you can see the differences between acute and chronic. Acute happens quickly, chronic happens over a period of time where they have had lower, or acute pyelonephritis that turns into chronic. Okay, again, how would we assess those and diagnose those patients that have acute?
Urinalysis?
Yep. What else, what other things can we do? Is there some kind of x-ray? Yes. Okay, then the urine culture and sensitivity, and then we're gonna manage that with, PO or IV fluids, antibiotics, and then, of course, the culture. Now, chronic is one that happens over a longer period of time. Again, a lot of people don't have symptoms with it, but some do. I've had pyelo before, and I didn't really realize it, but, until I had hematuria. So, how are we gonna diagnose a chronic pyelo? We're gonna do IV urogram, the creatinine clearance is usually 24 hours. The BUN, and then of course creatinine levels tells you how the kidney is functioning. Okay? What are some factors contributing to a UTI? So when you put in a Foley catheter, the main reason that we keep it sterile is so bacteria doesn't get in there and cause them to get even more sicker with a UTI. We're gonna talk about urethrovesical reflux in just a minute. Any bacteria that gets in the urine can cause that. Women do have a shorter urethra than men. And then, what are some risk factors for that? What are some symptoms or causes for UTI that I don't have on there? It's an easy one.
Hygiene?
Yes. So women that have not been educated wipe from back to front to back with the same thing, with the same tissue. Is that very healthy and clean? No. So we need to teach them and ask them how they're wiping to begin with if they're continent.
Also, wouldn't sexual activity?
It does. I think I'll mention that in a few minutes. So this is reflux here. This is a urethrovesical reflux. Okay, so it's supposed to go down, but what's happening right here?
It's going back from the urethra to the bladder.
Yes. Okay, so that's reflux when it goes back up in. And then this one here, what's happening there?
It's going from the bladder to the ureters.
Yeah, the small amount of residual urine, which I'll talk about in a few minutes, can go back even farther up into the bladder. And then, so this is a urethrovesical reflux. What is this right here?
A ureter?
Yes, and what is this?
No?
Urethra.
Yeah.
This is a ureter, this is the urethra. So the urine is gonna back up here, that's where that reflux comes from. That can cause infections too. And then this one here, what is wrong with that? It's blocked, so you can't get any urine out, okay? What are the common symptoms that patients have with a UTI? How many people have had a UTI? Not many? Nobody? Okay, me, okay. So what are the symptoms that are common with a UTI?
Urination, pain in the pelvic area.
Right.
We just had one.
Yeah. So there's pain, there's urgency, frequency, yeah, cloudiness in the urine, yes,
Blood in the urine.
exactly. Okay. Like we mentioned before, it's associated with sexual intercourse. and properly putting contraceptives in there and personal hygiene. And what do we need to teach to older patients? We need to, pardon?
Drink water.
We do, but what are we gonna ask them to do that they can do? We're gonna ask them to go to the restroom, like every 2 hours, especially if they're incontinent. What we've got to do is retrain them like you would a toddler. We take them to the bathroom, make sure they go or not, but at least they're getting used to it. Okay, so we're gonna do a urinalysis, urine cultures, and probably, an x-ray of the kidneys, okay? Any questions so far? You know how Ms. Nancer feels about the UTI nursing diagnosis, so y'all can see that here. I agree with her when it comes to that, yes. Okay, so what are some of the symptoms we already mentioned with a UTI? What can it lead to? Yes, you don't want it to get that far, but it does quickly. It can, and then from an acute kidney injury, remember I was talking about the football players that get hit in the back, or even low down here, it can cause problems, yes. And then chronic kidney disease that leads to dialysis a lot of times. How are we gonna manage this patient with a UTI? What's the number one thing we're gonna do?
Antibiotics,
That is, yes.
drink lots of water.
But what are we gonna do with their pain?
You can prescribe pain meds, you can encourage them to use a heating pad on their abdomen.
You're so good, yes. So the main thing is that they will get up, go to the bathroom. We will give them medicine. There is Peridium that stops the spasms. And what color does Peridium turn your urine to?
Orange.
Yes, so if you see orange urine, that means that they are on Peridium. Make sure they're voiding, relieve their pain and discomfort, but be careful of Tylenol and Motrin when you're doing that. And then teach them how to prevent that. How would they prevent a UTI? I just mentioned it earlier.
Frequent voiding.
Yes, watch their diet, make sure they have 6 to 8 glasses of fluid a day. Okay, and that's 8 ounces too. And then hopefully they'll progress and they won't have any complications. Okay, we've already done that. The interventions we already mentioned, relieving the pain with pain medicine. Hopefully it may be something IV instead of Tylenol or Motrin. Medicines, we mentioned that too, antibiotics, pain medicine, and then antispasmodics are like Peridium. Okay. And, what's your name? Zoe mentioned in the next thing to relieve that is the applying heat to the perineum for pain and spasm. So when they spasm, they cannot get any urine out and it's very painful. Increase their fluid intake. We want them to drink what? Water and what else? What other juice is good? Yes. Avoid irritants. That's usually anything that's got caffeine in it because it will constrict your blood vessels. Coffee, tea, citrus, it's got a lot of acid in them. The spices do. Coca-Cola does dehydrate them, and so does alcohol. Okay. So how many people in the United States have urinary incontinence? And it's mostly older people. There's a lot of people, 25 million. It's underdiagnosed and underreported because people are embarrassed. Yeah, we're not here to judge, we're here to help. It affects everybody, and the risk factors for that, we've already mentioned before. But what is a risk factor for a UTI? Could it be your age? Yeah, because some things just happen normally. If you don't do Kegel exercises, then they can become incontinent. Okay. these are the types of urinary incontinence, stress incontinence. That's when somebody takes them to the bathroom, they're like, you pee on command, you're gonna go now. No, we're not. Urgency can cause it, any kind of, imbalanced function in the kidneys, any diseases, and then it can be mixed. Alright, so how are we going to help these patients? Like I said earlier, we can tell them that a lot of people become incontinent. Everybody does not, but it is treatable if they have it. And like I mentioned, training a toddler will train the adult again on how often they're peeing, the amount of fluids that they're taking in, those kinds of things. And their diet, what they're eating. So we can encourage them to put that voiding into a log or diary so that they can bring that to their, urologist appointment or their physician. Help them behaviorally, let them know that incontinence is not inevitable and it is treatable, okay? Then with medications, we're gonna give them antibiotics usually. And we talked about strategies for promoting continence. Urinary retention is what? What is that? It's when they're holding on to urine. They can't get it out. So how do we measure that? We did it on the floor, I think it was this weekend. Yes, a bladder scanner is like a little ultrasound that's got a ball on it, you put jelly on it, and you just put it over the bladder and it will tell you how many milliliters of urine are in the bladder. So that means, is it residual? Yes, okay. Causes can be adults over 60, and they can have up to 100 milliliters of urine that remains in their bladder. Post-operative, what do they have usually? Because their bladder, when they put people to sleep, their whole body goes to sleep. And it takes a while for people to wake up. Okay, the ever popular diabetes is showing its ugly head again. Then prostate enlargement. So what happens to the prostate is it gets bigger and bigger, then it blocks the urine. Okay. Any kind of diseases, any trauma, like with those football players, pregnancy, when you have a big baby and it pushes down on your bladder, what happens? It hurts, and they can't get all the urine out. And then the medications, of course, the antibiotics and things for bladder spasm and pain. What is a neurogenic bladder? Can you relate it to diabetes? How? So a neurogenic bladder is one that has lost some of the sensation with a patient. They can't even tell when they've got to use the bathroom. That causes incontinence too. So it could be spastic, where it empties on reflex without control. That's like a violent cough. Of course, some women, like a lot of other women, need to do those Kegel exercises. And then a flaccid neurogenic bladder is the other type that's caused by lower motor neuron lesion, such as a traumatic injury like we talked about. Okay, so how are we going to assess this patient? What's the main number one thing for urinary retention? What are we gonna check? We just
I found
mentioned.
this on the web, is that number one?
Input and output?
Yes, we're gonna, make sure that they are equal, and then it can lead to infection. We've discussed incontinence, we're gonna give medications, and then some people may have to have bladder neck, correction. So catheterization, how many of y'all have put or inserted a catheter? Male or female, doesn't matter. So that's the majority, okay. Alright, so the one thing that we've got to remember when we're catheterizing somebody is it is a sterile procedure, period. Urine, believe it or not, is sterile when it's in the bladder. When it comes out, that's a different story. Okay, so we're gonna talk about indwelling catheters, which are the Foley catheters that range from, I think, 18 to like 22. Suprapubic catheters are smaller, they go directly into the bladder, and we're gonna make sure that the older people, know what it's about. You know they're gonna have a UTI and they're gonna be confused, so you may have to spend a little bit more time with them. So the management is to minimize the trauma when you're inserting it. We're gonna do bladder training, which we talked about. And then another way that we can do it at the bedside is you can crimp the Foley catheter and teach them how to void again, okay? Does that make sense, y'all? Okay. So that crimping is like the bladder holding on to the urine. And we're gonna try and get them to say that they can feel the sensation. And this is a suprapubic catheter. How many of y'all have seen these before? Okay, so it goes directly into where? Yeah, does that look sterile to you? There's a problem with this picture. And what is it?
It needs dressing.
Right there, yeah. It's broad, it's open, anything can get in there. Make sure that they wash their hands when they're dealing with a suprapubic catheter, and they can get infections, and they're not very pretty.